ACME board, which is the Asian Collegium of Medical Education, and the Bangalore ISCCM chapter to invite you all to this monthly CME meet. In Bangalore, we have this policy of different hospitals presenting, CMEs, alternatively. And this month, it happens to be the Columbia Asia Referral Hospital, Yeshwanthpur. And it gives me great pleasure to introduce today's speakers, both close friends of mine. First speaker will be Dr. Karthik Rao, intensivist. He will be speaking on nutrition in critically ill, followed by a talk by Dr. Pradeep Rangappa. He will be speaking on protein in critically ill. Do we have a clinical equipoise? And followed by a third guest lecture, and that is a pharma-sponsored lecture by Dr. Jaishid Ahdil, who happens to be head of medical affairs. So as the speakers come on, I will be introducing. So over to the first speaker now, Dr. Karthik Rao, who's going to speak on nutrition and critically ill. Over to you, Karthik.
We cannot hear you, sir. We cannot hear you, Dr. Karthik.
Okay. I've unmuted myself.
It's unmute, but your voice is very low, sir.
Should I use a earphone?
Sure, sure.
Karthik, we can hear you, Karthik. You're audible.
Oh, okay. Shall I start off?
I think so. Yes.
Okay, fine. And the screen is visible, right?
Yeah.
Yes.
Okay, right. So I'll start off. So coming to nutrition and critical illness, this is such a vast topic that we can do workshops for days together. So covering this in the next 15 to 20 minutes is going to be a challenge for me. But I'll try to make some justice out of the whole thing. So why do we need nutrition? Some people live to eat, some people eat to live. But when you're critically ill, the most important thing is we have to eat to live, right? So we need to give patients some sort of a nutrition so that at least their malnourishment is taken care of, because they are prone for malnourishment. So we need to give them adequate calories, proteins, electrolytes, vitamins, minerals, etc. The reason being, any patient who is critically ill will be in a hypermetabolic or a catabolic state. And their nutritional requirements obviously is much, much more than a normal person. They also deteriorate very rapidly and get malnourished, and this can be attributed to the acute phase responses. And once malnutrition takes over, there'll be a lot of changes within them which can deteriorate and get them further down. So in terms of altering their immunity, susceptibility to infections goes up. So proteins being the backbone of all of these is known to go very low when the patients are malnourished. And when proteins and the malnourishment takes over, protein deficiency and malnourishment takes over, the circulating immunoglobulins go down, the macrophage functions alter, tissue repairs get worse, and oxidative stress also goes up. So this is when patients go down the drain, and then there'll be irreversible loss of muscle and protein mass in them. Practical approach for a patient who is critically ill, we should be very aware of when nutrition supplement should be initiated, what are the routes of delivery, and what do you do in disease-specific conditions. This also becomes very important for us to know. First, let us answer the question, why do we need to do it? Why do we need to give them nutrition? As I answered partly, it is a catabolic stress state. Patients would be in SIRS or sepsis of some sort, so their requirement goes up significantly. They can get into complications of infections, mortality and morbidity goes up significantly, and they get into multi-organ failure. And when you supplement them with adequate nutrition, the metabolic response to stress comes down. They also can be favorably modulated, the immune response in mind. And giving them adequate nutrition is going to decrease the length of the hospital stay, decrease the morbidity rate, and also improves their outcomes in these patients. Next question to be answered is, how do we do it? So before we go into how, we need to assess them in terms of the nutritional status. And this is a very, very difficult proposition, especially in a critically ill patient, because there are a lot of things that we need to take in account. Anthropometric measurements are not the best of the things that we can have. And if you look at the body weight, any patient who loses 10% of the body weight is considered to be significantly down. If there is a 20% loss, then it's termed as critical. And when they lose 30% of the body weight, that is considered as being lethal. What causes the loss? All of these diseases. The acute phase response causes it. Insulin resistance can be a attributing factor. There'll be a lot of catabolism within the patient. And all of these cause metabolic changes in them, which can lead to lean body mass loss. So as I said, 10% is significant, 20% is critical, and more than 30% is lethal. Now, apart from the body weight, there are other measurements that can also be done from the anthropometric point of view, which is mid-arm circumference, which is skin fold thickness, as in kids, head to circumference ratio. Again, that's in relevant pediatric patients. Head to chest ratio. All of these are very, very non-specific measures. There is another thing where body weight also is taken into account, which is the BMI, which is body mass index, which is given by weight in kilograms by height in meter square. And a low BMI or a high BMI can independently predict whether the patient is going to do well or not. Apart from these, there are other biochemical tools where you can look at the hemoglobin, look at the albumin, look at the transferrin, the prealbumin, or the lymphocyte count. There are clinical assessments which are more practical. A good nutritional history can give us a very good analysis of how the patient has been eating, whether the patient is physically low on body weight, loss of subcutaneous fat, there's a lot of edema or ascites, which means that the proteins are low in the body. So these are clinical assessments. And dietary assessments can again be a surrogate marker where we will look at the food frequencies, the food consumption, what the patient had had in the previous meal, etc. So these are other ways of assessing the patient's nutritional status. If you are more concerned, then we can get into this Harris-Benedict equation, which is a mathematical formula taking the weight and the height and the age into account. There is also a resting energy expenditure, which can be made use of to look at the requirement of the patient's nutritional status. There is a very simple bedside process which takes into account no formulae, no tools at all, and it can tell you very roughly whether the patient is well nourished or moderately nourished or severely malnourished. So it takes into account the weight loss in the previous 6 months, the diet that the patient is having, any loss from the GI things, the disease types, subcutaneous fat, muscle mass, edema, and ascites. So based on that, category A, B, or severely nourished, so that can be made out. So whatever it is, we need to make sure that we are providing adequate energy and fluids to the patients. So any critically ill patient, especially in post-operative conditions, can require up to 25 kilocalories per kg in a 24-hour period. And if the patient has got a lot of sepsis on board, burns and polytrauma, the requirement for energy can go up to 35 kilocalories per kg in a 24-hour period. And if the patients are febrile, for every 10-degree rise in the temperature, we have to add in another 10% of the calories. The third point is very important, where we are not very, very crucial. I mean, it's very important actually. We don't take into account being the water requirements for adults. It's 30 to 35 ml per kg per hour. And anybody who has a febrile illness or requirement goes up, so you can add in the extra bit of water as an additional thing over and above what we are already giving him for every 10-degree rise in body temperature. We need to make sure that we're giving micronutrients and macronutrients to these patients. Macronutrients is something that we commonly know. They are the proteins, carbohydrates, and lipids. So when we come to proteins, they provide almost 10 to 15% of the calories. And if anybody has got a normal metabolism, the daily requirement of the protein is 0.8 to 1.2 grams per kg. And in hypercatabolic state, like in sepsis and burns and polytrauma, it can go up to 1.2 to 1.6 grams per kilogram. So that is a requirement for proteins. If it's carbohydrates, we have to make sure that they provide 50 to 60% of the total calories and 70 to 90% of the non-protein calories. We know that carbohydrates provide 3.4 kilocalories per gram of glucose, and we need to make sure that this is being given properly. When we're talking about lipids, we know that lipid emulsion provides 25 to 30% of the total energy, and the maximum dose should be limited to 1 gram per kg in a 24-hour period. Lipids provide typically 9.3 kilocalories per gram. So that is something that we have to remember. There are a few daily requirements for electrolytes. If you give it to the enteral route or the parenteral route, there are daily requirements for these trace elements being chromium, copper, fluoride, iron, manganese, selenium, etc. And there are also daily requirements for the vitamins that we can give. So all of these are definitely in terms of enteral route as well as parenteral route. So these are the water-soluble vitamins that can be given on a daily basis. Of course, it is very difficult for anyone to make sure that you give it precisely, but these are the recommendations as per the guidelines. So the fourth question we have to answer is, when do we give them nutrition and how to do it? It's important to start it as early as possible. And at least in the first 1 or 2 days, we have to start off nutrition in anybody who's critically ill. If the patient is hemodynamically unstable, we obviously have to take care of the first things first. Make sure that the patient is resuscitated adequately from the shock, and then you can start it off. And if you are not able to give the full feeds, at least give half the feeds in the first 72 hours, and make sure you reach 100% at least by day 7. And in the worst come worst scenario where you're not able to feed them at all for the next 1 week, then that is something when you consider as a total nutrition can be given. So coming to the enteral nutrition, which is the most common route in the ICU. So why do we prefer this route? It's more physiological, it is cheaper, it is non-invasive, it maintains the intestinal immune integrity, it maintains the immune and gut barrier functions, it reduces the morbidity, reduces the hospital and ICU length of stay, and also the mortality. The more you delay the enteral nutrition, the more is the mortality in these patients. So we have to reduce, I mean, if parenteral nutrition is considered, we know that there's a lot of infections. So to prevent infections, enteral route is the best way to go about. How do we do it? What is the protocol for feeding these patients? You have to start off within the first 24 to 48 hours. If the patient is a post-surgical patient where there is a laparotomy that has happened or some major abdominal surgery, make sure we discuss it with the surgeons to make sure whether we can give the enteral route immediately or not. And make sure that the patient's head end is elevated before you initiate the nutrition. And they should have nasogastric or orogastric tube. It could be either be a nasogastric tube or an orogastric tube or some sort of a gastrostomy tube or a gastrojejunal tube, whatever it is. Make sure the enteral route is most preferred one. Current recommendations, as I mentioned earlier, would be to target the energy and the protein intake to the recommended standards. How do we select the formula? If the patient's GI functions is near normal or normal, we have to go with the commercial tube feed with the polymeric formulas. For example, the commonest things that we use would be Ensure or Cabipro. If you look at the molecular, I mean the brand names of these, where they provide proteins, carbohydrates, and fats very similar to what we give in the normal diet. They can be divided as the ones that contain fiber or the ones that contain no fiber. There can be lactose-free formulations also available. If the patient is not having a good GI function, then we can go on to elemental formulas where we have easily digested forms of proteins, carbohydrates, and fats. Proteins can be in the form of amino acids and peptides. Carbohydrates can be in the form of mono, di, or oligosaccharides. And fat can be in the form of medium chain triglycerides. So we get fiber-free ones, we get low lactose ones, and we get those which have a higher osmolality also. Examples being Critipro or Nova Source peptides. These are just the brand names. I'm just thinking from the bottom, I mean, from the tip of my tongue. If the patient has got a lot of diseases where you have to look into, then there are other commercial tube feeds which can probably be catered to for these specific conditions. For example, if the patient is diabetic, there are examples like Luzerna, Fesbendium. If the patient has got a renal problem, then we have things like ReniPro, resource dialysis. All of these are disease-specific formulations which can be used, which can be addressed to these patients, making sure that the specific targets are met. When do you not give enteral nutrition? So when the patient has got complete gastrointestinal dysfunction, when there is a prolonged paralytic ileus, patients with short gut syndrome with major surgeries, those who have upper GI obstructions, or those who have severe septic shock where absorption is not happening, malabsorption syndromes, and severe pancreatitis which have generalized peritonitis. So all of these become contraindications to enteral nutrition, and in turn, these are the indications for parenteral nutrition. So whenever we are using a feed formula for enteral nutrition, these are the requisites that we have to follow. One is provide balanced micro and macronutrients. We have to give stable nutrient compositions. The calories should range from isocaloric to 1.5 kilocalories per ml, and the condition-specific feeds have to be taken into account. How do you select the patients? We have to make sure that the digestive and absorptive capacity is taken care of, the disease status and the organ dysfunctions are looked into, and nutrient-specific formula are given. We also have to take into account that we have to make sure that the patients tolerate what you're giving. because if they're not tolerating the feeds and they get into diarrhea, then there's no point in persisting with the enteral feeds. Very rarely, or earlier, in earlier days, we used to give a lot of these kitchen feeds, and these were the timings that we used to follow, the feeding schedule. But we no longer stick to these formulas because the commercially available feeds are much, much more specific and much more clearer than the kitchen feeds that we give. What do you do in hemodynamically unstable patients? We have to make sure that that functioning is proper, and it has to be initiated when the patient is adequately fluid resuscitated. He has to be on at least less than 2 vasopressors, and then you can start it off. And you have to make sure that you have to start it off as early as you can. There is also another concept called as immunonutrition when you talk about enteral nutrition. So immunonutrients are those nutrients which are used to modulate the activity of immune system. So what that does is it attenuates the metabolic response, it prevents oxidative stress, it favorably modulates the immune response of the patient, and makes sure that the glycemic control is taken care of. So these are immunonutrition. And the common things that are used are, one is arginine, the next is glutamine, the next is omega-3 fatty acids. These are the three theoretical advantages. Arginine is a primary fuel for fibroblasts. It preserves the lean body mass. It is anti-catabolic. It stimulates growth hormone. Glutamine has got all of these properties where protein synthesis is taken care of. The nucleotide synthesis is taken care of. And we also have these EPA, that is eicosapentaenoic pentanoic acid, which is omega-3 fatty acids, which modulates the inflammation. It supports the immune function, and so on and so forth. Though these are the advantages that are seen with these immunonutrition, there are a lot of studies which say that individually collected data have not shown any significant difference by any of these independently. But collectively, they all do help in getting the patient out of the ICU, reduce the length of hospital stay, and improves the outcomes. There are other antioxidants that we have to think about, which is vitamin A, vitamin C, zinc, copper, and manganese, and the individual functions of these elements are as given in these slides here. There is a concept about being probiotic and a prebiotic. A probiotic is a preparation which contains a viable microorganism in sufficient numbers which can alter the gut microflora and exerts a beneficial effect on the host. So these are things that can be given, considered at least. So critical illness has causes virulence of the gut bacteria, and probiotics help in that. It inhibits the growth of pathogenic bacteria. It blocks epithelial invasion by pathogens. It eliminates the pathogenic toxins and improves the T cell and macrophage function. So these are the advantages of giving a probiotic. But again, as I mentioned earlier, independent studies have shown no advantage with the use of either a probiotic or a prebiotic in sufficiently large numbers of samples of patients. So all of these individually may not be of any use, but when given along with the normal nutritional requirements, definitely helps in patients' outcomes. So that's a probiotic, for example, a curd, and a prebiotic is something which is called as a pre-digested food ingredient. It affects the host by selectively stimulating the growth or activity of one or a limited number of bacteria. So there are a lot of nutraceuticals that are available in the pharmacy, the use of which, as I mentioned, may or may not be helpful in an independent patient care. There are other disease-specific diets that we have to think about. Somebody coming with hepatic failure, enteral route is preferred definitely. If you're thinking of giving branched chain amino acids for these hepatic failure patients, there are no major beneficial effects. Protein supplementation is definitely recommended in renal failure, and protein restriction is advised only if the patient is really, really sick, and it has to be avoided in refractory encephalopathy. So the requirement will be almost similar to what a normal critically ill patient will be needing. If you're talking about a patient coming with traumatic brain injury, initiation of early enteral nutrition is definitely the way to go. And once a patient is hemodynamically stable, obviously you have to start it off with full feeds. Protein recommendation should be in the range of 1.5 to 2.5 grams per kg per day because it is a hypercatabolic process. There is a theoretical advantage of giving arginine containing immune modulation formulations also in these patients. If the patient has got acute kidney injury, we have to stick again to the enteral route, obviously. Protein should not be restricted in those with acute renal insufficiency, and the dietary protein intake should be 1.2 to 1.7 gram per kilogram, right? And other things like low potassium, low phosphate diets, etc., can be used in these kidney injury patients. The common approach to nutritional support, we need to assess the nutritional status of the patient, screen the patient properly, you get a proper history from the relatives to see whether the patient is malnourished or not. If they are malnourished, then that's the way to go. And if they are not, then if the GI tract is functional, enteral route is the way to go. If it is non-functional, then the parental route is the way to go. And the decision tree for optimal nutritional support would be something like this. If you're considering enteral nutrition, if you are thinking of giving them enteral nutrition, anticipating for less than 6 to 8 weeks, nasogastric tube is the way to go. If it is more than that, and if you think that it has to be prolonged, then the best thing to do is gastrostomy. And post-pyloric feeding is given in these conditions where the patient has got severe nausea, acute pancreatitis, patients with delayed gastric emptying, high surgical anastomotic state, and high risk aspiration. So the way to go is nasodiodinal or a nasojejunal tube. Make sure that it goes beyond the pylorus so that regurgitation is avoided to a large extent. Few slides regarding TPN, because TPN is not something that we commonly use in the ICU because it is not the way to go. Indications for TPN, as I mentioned earlier, any contraindication to enteral feeds becomes an indication for TPN. So TPN is considered for very short-term use because the prolonged TPN definitely gives rise to sepsis, and it's an independent predictor for mortality. So anybody with a bowel injury, anybody with major surgeries, traumas, burns, bowel diseases, for example, severe obstructions of fistulae, severe malnourishment, and malabsorption, etc. So all of these reasons can be given for total parenteral nutrition. It can be given via the central route or a peripheral route. The advantages of a central nutrition are it can be given for a longer period of time. It is a hyperosmolar solution, and the full requirement of the nutrition can be given with the TPN, central TPN. The problems are it needs a central line, it is expensive, there are a lot of side effects. Coming to peripheral nutrition, it can be managed with just a peripheral line, so the requirements are very minimal. It can be given for a short period of time, less than 2 weeks. The osmolarity is low. It can give less than 100, 900 milliosmoles per liter. Large volumes can be infused through the peripheral line. The only disadvantage would be thrombophlebitis, so you need to keep changing the peripheral line as and when it gets thrombosed. You need to monitor to prevent overfeeding, to avoid respiratory issues, to promote nutrition, the nitrogen retention, and so on and so forth. So you need to monitor the patient more closely when they're on total parenteral nutrition. There can be a lot of complications in the form of mechanical complications, predominantly related to the catheter. Infections, again, predominantly related to the catheter. There are metabolic complications in terms of early and late. The early complications would be volume overload, hyperglycemia, refeeding syndrome, hypokalemia, hypophosphatemia, hypomagnesemia, and hyperchloremic acidosis. So these things have to be borne in mind, and they have to be addressed to whenever the patients get sicker. The late complications include fatty acid deficiency, trace mineral deficiency, vitamin deficiencies, bone diseases, hepatic steatosis, and cholestasis. There is something called as a transitional feeding also, which where they maintain full parental nutrition support until the patient is tolerating 1/3 via enteral route. So what they do is they slowly start decreasing the TPN by 50% and slowly keep increasing the enteral feeding. Right? So this is something that is given as it's not a common practice that is done, but if patients are not able to be enterally fed, this is something that has also been advised and advocated in a lot of centers. So that's about it. And the last slide is to eat is a necessity, but to eat intelligently is an art. Thank you. So as I mentioned, it is a very, very rapid run through of the entire nutritional thing in the just a 15 to 20 minute period. Very difficult to cover the entire aspects of nutrition, but this is what we can probably consider. Thank you.
Thank you so much, Karthik. I think you have simplified nutrition in critical ill in the time allotted to you very nicely. And I think you have touched on all the aspects of nutrition with regard to enteral and parenteral. And I think you have rightfully also mentioned that enteral is the way to go. And all of us as practicing intensivists always emphasize on enteral, unless for the indications that you showed that if there is any breach in the gut and we are not able to feed for whatever reasons, only then do we consider parenteral nutrition. And even the European Society and the American Society for Parenteral and Enteral Nutrition, says the same thing. Thank you. Do we take questions, Vinay? Or,
yes, so there are two questions. We can take it now or we can take it in the end.
I think we could take it after my talk together.
Okay, fair.
Farooq,
Yes,
because
Pradeep.
then me and Karthik can finish nutrition, then we can dedicate entirely to the antibiotic stuff.
Sure, Pradeep. Okay, so we move on to the second topic now. Again, a pleasure to introduce the second speaker, Dr. Pradeep Rangappa, who's currently the Vice President of the Indian Society of Critical Care Medicine, a good close buddy of ours. He will be speaking on protein in critically ill. Do we have a clinical equipoise? Over to you, Pradeep.
Right. Good evening, everyone. So hope you can all see my slide. So initially the thought was that I will talk on the journal review in nutrition because that's always my area of interest to review all the new journals. And honestly, this is the journal review, what I'm doing, because I looked into last 1 year. And for all the listeners, you will be pleasantly surprised. There is no landmark article in nutrition that has really come in 2020. So the only article that I could trace is this particular article. So what I'm today doing is actually a journal review of in year 2020. There's nothing at all that is come pertaining to nutrition that is very new. And to that effect, there are one or two articles which has made its print on COVID and nutrition, but there's nothing to talk on that. It's just the repetition of what we all know. So it's just to put a COVID context into it. Just to take mileage out of this whole situation. But apart from that, there's nothing unique to COVID that we can talk about nutrition in specific. So as my good friend Farooq has said, so these are series of meetings that we would be doing as monthly ISCCM meets that we were doing. We have just called it as run up to GICS because, the GICS, as you all know, has been postponed, Global Intensive Care Symposium, to next year. So we would do this every month as a series, until we manifest this real conference. So this is a good topic. So this was a very detailed article which has come on do we have clinical equipoise about how much protein to provide to critically ill. So as friends, you would all know who are listening to this that the proteins is a very debatable topic as to what is the right amount of protein to be given in critically ill patients. That has always remained a debate with a lot of studies that have happened. So I'll just take you through the narrative as to what we know about the proteins in critical ill and what should be our concepts. So when we look at choice of enteral formula, I think Karthik has given a good overview about nutrition in general. So I'll be confining this only to the proteins. So when you look at choice of enteral formula in critical ill patients, you can divide it to basically 4 categories. What we generally give to anyone who has a good preserved gut function is standard polymer. And any feed should have 3 components. Would have a protein component, carbohydrate component, and a fat component. And so standard polymeric, you would have intact proteins which individual has to digest, and it would have complex carbohydrates in some proportion, and fats in the form of long-chain triglycerides. And this is given to any individual whose gut integrity is preserved and who can digest like any normal individual would do. And proteins, they are either derived from the soya or from the poultry or from the meat.
So sorry to disturb. There's a lot of disturbance in the voice.
So what am I meant to do, Vinay? Because my internet, okay, I'll just try to connect through, because I connected through my iPhone, my current had gone.
Okay.
Is it still not very clear?
There's a lot of crackling noise, sir.
Okay,
so you can keep your mic a little closer, sir.
I'll just connected through the.
Now it's fine, sir. Now it's fine.
Is it okay now?
Yes.
Okay. So the second group of proteins we would talk is on elemental diet, where we break down the proteins into individual amino acids, because there is some gut dysfunction where they cannot break down the protein. So we break the protein down into individual amino acids and give it. We call it as elemental diet. And again, there, the fat component, we would lower the amount of long chain triglycerides. And here they would require some sort of a minimal digestive function. So the typical situation where we would think of giving elemental would be a pancreatitis, where you have a disturbance in the pancreatic juices. So then you have a third component, which is semi-elemental. So you break down the elemental into further components where protein is further broken down or hydrolyzed into peptides. So we give it as oligopeptide, bipeptide, and tripeptide. They get broken down from amino acids. So this is the more simplified version of delivering protein. And here we don't use long chain triglycerides, we use medium chain triglycerides. And this is something one would give in a short gut, or where there is extensive gut resection that has happened, and where there is absorption limited to only water and electrolytes sort of a situation. Then you have organ specific nutrition, where there are certain nutritional components catering to certain organ dysfunction like end stage lung disease, liver disease, or renal disease. So this is in broad how we look at delivery of proteins in various disease condition. So that is something for listeners to just keep in mind. So if you look at ASPEN guidelines, ESPEN guidelines, and our Indian guidelines, the general ballpark for protein recommendation is 1.2 to 2 grams per kg per day. That gets a recommendation of 1A. So which is a strong recommendation, good level of evidence. And the ballpark figure for delivering calories would be 25 to 30 kilocalories per kg per day. But if someone is very hyper catabolic, then you would give kilocalories ratio to nitrogen as 120:1. And if you're dealing with a special circumstance like burns, then you would possibly use a Toronto formula and adjust the nutrient component. But for listeners, just 1.2 to 2 grams per kg per day is the protein allocation recommended by most guidelines. Take it ASPEN, ESPEN, Indian guidelines, and the calories is 25 to 30 kilocalories. So if you remember that, that should be good enough. So we'll jump into the whole science of protein. So when we give, the whole concept of we giving protein is to maintain the internal protein balance in a human being, and that is with an intent that we maintain the muscle mass and we retain the strength of the muscle. So that is the whole intent. We sort of titrate and customize the protein delivery, and whether by providing adequate protein, whether it improves the survival of the patient and enhances the recovery, we do not know for sure. That's where the whole science lies, and that's where the studies happen. And as I said in the previous slide, the ASPEN suggests 1.2 to 2 grams per kg per day as the protein allocation. And in special situation where they're hypercatabolic like burns, trauma, the proteins could be cranked up to 2 to 2.5 grams per kg per day. Okay. So in critically ill, the studies have shown, the Canadian study, there's one which is done, which showed the average delivery of protein that one would be delivering would be 1.3 grams per kg per day. But this particular study from Canada has shown that, albeit you may write 1.3 grams per kg per day, but the actual protein that gets delivered into virtual reality would be only 0.7 grams per kg per day, which means, albeit your intent is to give 1.3 grams, only 55% of the effective protein gets delivered because of various reasons, because of interruption of the feeds, because of the absorption issues and all that. So which means to say, although we put as 1.2 to 2, if you target 1.3 on am I audible? Because my internet, see, my current is come and gone.
We just lost you for a.
Yeah, because my current is come and gone, so I have some issues with the current here. So
Okay.
am I audible now,
yes.
or is the
Yes,
PowerPoint seeing?
Yes, sir.
Okay. So my voice may still crackle because I'm connected to my iPhone now. Okay. So just tell me if my my voice is not very clear. I'll change over to the regular current regular internet. So what does this evidence say? As I said, although we intend to give 1.3, but we fall short in delivering the adequate amount of protein. So what does our evidence say? So basically, you have three groups of studies. So there is a big number of randomized controlled trials. There are 5 RCTs, which has looked at whether high protein is good or low protein. And there are little more than 5 randomized controlled trials in the form of observational studies, which give you a different message. We'll just go through. So these 5 RCTs are landmark articles which has compared low protein versus high protein. And the sample size in these studies has been 20 to 470 number of patients. And the quality of the studies rated on 14 was 7 to 10. And these studies were done between 1985 to 2017. So these were the studies comparing. So the first trial I would talk, which came in 2017 by the Danish group, was EAT ICU trial. So this is also a landmark trial. So this trial, as you see, took 199 mechanically ventilated patients, and they compared two groups. One, they called it as a higher protein group, 1.5 grams per kg per day. The second one was 1.2 grams. So there was only a difference of 0.3 grams per kg, 100 in intervention and 99 in control group. And when you look at the results of the study, 28-day mortality, 90-day mortality, 6 months mortality, infection, duration of mechanical ventilation or performance, there's absolutely no difference between little higher protein versus lower protein. And what they ended up giving, the authors found that in the zeal to give more protein, they ended up giving more calories. And that led to sort of worse hyperglycemia, which was troubling for them. So basically, first randomized control EAT ICU trial did not show difference between high protein and low protein. Then this particular trial came by Australian group in 2016, protein requirements in critically ill randomized control trial. Here they gave that extra protein with parenteral nutrition. So here they had 119 patients. They had a higher protein group got 1.2 grams per kg per day, and the lower protein group got 0.8. As again, you see 0.4 grams is the difference between higher and lower. 59 in higher protein group, 60 in lower protein. Again, if you look at the data, when you look at all the endpoints, ICU mortality, hospital mortality, 6 months mortality, infections, duration, which are typical endpoints they looked at, there's absolutely no difference between higher protein and lower protein group, which again goes on to show either you give 1.2, 1.5, 2, it didn't make a difference. But what they found in the study was it significantly improved the muscle mass and it increased the hand grip. So basically they felt higher protein group had a better strength. And this is more of a subjective assessment. And as again here, protein difference is 0.4 grams, which authors say it was pretty small. So then this particular study again came from Australia in 2015, intravenous amino acid therapy for kidney function, a randomized control trial. So here again, they looked at 474 patients where they gave amino acids to crank up the proteins. They gave an additional amino acids of 100 grams per day in the higher protein group and compared to the standard. And again, if you look at the endpoints of ICU mortality, hospital mortality, 90-day mortality, and duration of mechanical ventilation, there was absolutely no difference between the intervention and the standard group. So you saw 3 randomized control trials. All 3 were negative when you compared high and low. Then this particular trial came from the Colombian group, which again by Rugels et al. Here they compared high protein and low calories versus standard group, which was isocaloric. And here, if you see, the high protein group got 1.7 grams per kg per day, but they lowered the calories to 15 kilocalories. And the standard group got 25 kilocalories per kg per day. So they had 80 patients, 40 in each group. And obviously, the high protein group got 1.4 grams and the standard group got 0.76 grams. Again, here there was no difference between mortality and duration of mechanical ventilation. So now you have 4 randomized controlled trial studies. All 4 do not show any difference between high protein and low protein group. So then this was a little older study which looked in traumatic brain injury patients, higher protein and lower protein group. And again, here there was no difference in mortality and infection. So as you see, the 5 randomized controlled trials, which are the trials one would look at to compare between high protein and low protein, failed to demonstrate any difference between the higher protein group or lower protein group. But the exactly opposite message. So please bear little attention. Randomized control trial did not show any difference, but all the observational studies on the contrary tell you a different story. So these are all the observational studies where they showed that adding extra protein and or adding 1000 kilo, which amounts to 1000 calories per day for 12 days, significantly reduce the infection risk, reduce the duration of mechanical ventilation, and reduce the mortality. So the whole narrative from observational study is very contrary to the randomized control. So that is where the whole debate about this protein aspect would come in. Okay, so I'll just try to connect to my regular internet. Sorry. Vinay, am I connected?
Yes, sir.
we
Yes,
can
sir. Yes, yes.
Okay, sorry, I was just changed my internet because I didn't want iPhone. Yeah. So then we have this meta-analysis which came, which took in all those 5 randomized controls that we discussed. And what do you expect from meta-analysis of 5 randomized control trials? We did not show difference. Meta-analysis also did not show difference because P was not significant. As you see, diamond is stuck in the middle. So this was a very interesting study which came. So now the whole concept is changing towards, okay, well, how about the timing, whether timing of delivering calories would matter. So what the author suggests is protein requirement is more important than calories. And this was a study which came in 2016, which looked at how about 80% of delivery versus less than 80%. So now the authors tried to look at if you're able to deliver 80% of the target protein versus a group where you're unable to achieve 80%, whether that showed difference. And that showed some difference in reducing 60-day mortality, which means if you're able to deliver more than 80% of the target goals, it reduced the mortality as compared to the group where you have fallen short of attaining that 80% of the goal. So that was interesting, but they compared that with whether that applies to the calories. With calories, it did not apply, which means to say this particular study is a very important study which emphasizes the importance of proteins in trying to attain more than 80% of the target requirement to have better outcomes. But calories you can ignore because even if you fall short of 80% of calories, it really didn't make a difference. So this is a very important message this study sends out. Then whether there are any deleterious effects. Now you have a debate that, okay, I either use high protein or low protein, doesn't matter. But whether high protein causes any deleterious effects. So now the whole essence of the timing of protein comes into play. So here, this was a study from UK which said, if you are in a overzealous mode to give more proteins within 10 days, it enhances the muscle wasting. And this was an interesting study from IPANIC trial, which came in 2020, where they showed if you are overzealous in giving more protein within 3 days, it had a worse outcome in increasing the ICU length of stay. And this was another study which said when you give 80 grams protein versus 60 grams proteins in 1 week, it increases the risk of death. See, now you are moving from the concept of high protein versus low protein in general to the timing of delivery of high protein, because these studies are telling you if you give high protein within a week or maybe within 3 days, then it leads to worse outcome. So this is an important concept these studies have tried to highlight. Timing of targeting the protein also becomes important. And on the same note, this particular study, which came from US, said more than 1 week, if you give high protein, it has a protective. So again, you are seeing the change in the whole narrative. You can give high protein, low protein after 1 week, but within 1 week, if you give high protein, it may lead to deleterious effects. So now then the concept changed to how do we identify the patients who may benefit from high protein. That came from, they came out with a score called Nutric score. So Nutric score is like any other score in ICU, which tries to identify the patient who are at a higher risk of malnutrition by taking into consideration the age, Apache, SOFA, comorbidities, and the number of days patient has been in. So and it was shown that in multi-organ dysfunction, there is a loss of 1 kg of muscle mass per day in first 10 days. So as I said, the narrative from observational studies are very different. So these are the 5 observational studies which has come from Israel, Netherlands, Denmark, and Canada, where they have shown higher protein reduces morbidity and mortality. So this finding has never been shown in the randomized control trials. This finding has never been shown in the meta-analysis, but these observational studies, so 5 RCTs, no difference. 5 observational studies tell you that high protein reduces morbidity and mortality. And this was a study from Netherlands called Protein Vent study. Again, it shows if you give high protein within 3 days, it increases more. So we have 3 studies to tell you give high protein within a week or within 3 days, you would cause more harm than benefit. And again, they go, if you give very less protein also, it is dangerous. It increases 6 months mortality. So what does higher Nutric score means? Nutric score basically identifies patients who are at a higher risk of malnutrition. So there was a study called top-up pilot study where they took only the patients with high Nutric score and they gave high protein in them. And they showed in patients with high Nutric, if you give more protein, it improves survival. But in someone with a normal Nutric score, it really doesn't matter. Okay, so now we have spoken about randomized control trials, no benefit, observational studies saying high protein is better. Then we have this other group of studies which said if you give high protein within 3 days or 1 week, it causes more harm, it may increase mortality. Now the new set of studies are talking about just giving protein is not enough. We need to give protein with exercise. You need to combine it with exercise. And these are two studies which said you need to combine proteins with exercise. If you are just eating protein and not exercising, there's no benefit. And they say the increased benefit is by increasing the mass of the muscle, increasing the strength of the muscle, and increasing the function of the muscle. So that's about the whole concept of protein. What about in acute kidney injury? We know that 50% of our ICU patients would have some form of acute kidney injury, and 15% of them go on to need renal replacement therapy. And when someone is on renal replacement therapy, we know there is a lot of protein loss, and that leads to negative nitrogen balance. So the authors suggest from the studies that in someone who is on dialysis, to improve nitrogen balance, you need to crank up the protein up to 2 point, because all the guidelines say 1.3 to 2 grams, but in patients with AKI, because of impaired negative balance, the author suggests 2.5 grams per kg per day is what may be needed. And there are these observational studies with one randomized control study which show that higher amino acids in hemodialysis patients improve nitrogen balance. And this was a study which came way back, where they showed giving intravenous amino acids in severe AKI leads to faster recovery. So now the question remains, is it safe to administer higher doses of proteins bar amino acids in AKI? So it is considered 2.5 grams per kg per day is considered safe in general ICU patients, except when they have refractory hypotension or liver disease. So this was a landmark study which came from Australia to look at proteins in AKI, acute kidney injury. So this was a big study, 474 patients with high risk for renal dysfunction. They had 239 where they gave high protein of 2 grams per kg per day and compared to standard. And they found, in fact, the glomerular filtration rate improved in a group which was given higher protein, and dialysis rate was no different, and urine output also was significantly higher in patients who were given higher protein, in someone who have acute kidney injury or who are at a higher risk of acute kidney injury. And the whole hypothesis, physiological hypothesis, is when you give supplemental amino acids, it is shown to increase the renal perfusion. And they did a subgroup analysis of cluster randomized control trial. This came in JAMA, where they looked at 242 patients who are at higher risk of AKI, and they assessed that higher protein, in fact, led them to need less of RRT. So they were in, so it reduced the risk of them going on to needing renal replacement therapy. So this was another study which came from Israel, very small study, 14 patients who had non-oliguric AKI with creatinine clearance less than 50 ml. They compared higher amino acids versus lower amino acids. And the group which got higher amino acids, diuresis was preserved and they needed lesser fusamide for dialysis. So this was a post-hoc subgroup analysis of nephroprotective trial that came from Australia, where they showed if you give additional amino acids in patients with normal RFTs who are at a higher risk of renal dysfunction, it led to reduced mortality. But when you give this additional amino acids in patients who have already AKI, it did increase the mortality by 28.3%. So this is again a very dangerous sort of a signal that this study is sending, saying if they have AKI, be wary about giving supplemental amino acids. You can give higher protein, but giving supplemental amino acids in IV formulation possibly may cause harm, is what came out of this most recent post-hoc analysis that came in 2018. So I'm sure all the audience is confused now how much protein we should give. So I'll summarize it at the end, which will make it very simple. So now there are more trials that is coming. So just last couple of slides, there is a Nexus trial. The results are still awaited. And as I told you, we need to combine protein with exercise. So this Nexus trial is a Canadian trial, which is combining to look at high protein. They're providing protein of 2.5 grams along with cycle ergometry, along with an exercise, to look at whether it has a bearing on improving short-term functional improvement. And primary outcome, they're looking at 6 minutes walk time, and they're looking at the muscle mass, strength, and function. And the results of this Nexus trial will be out in 2021. So we need to see this trial, whether giving protein with exercise makes any difference in the outcome. I think this is a very important study which all of us should await and watch. This is going to be the landmark study called an effort study, which is being conducted by Aspen Group, by mainly Canadian investigators. It's the largest sort of a nutrition trial comparing high protein and low protein. It's a multicentric randomized control trial. They are taking whopping 4,000 patients with higher Nutrix score, which means they are identifying patients who are at a higher risk of malnutrition, big number, to see whether higher protein, and that the higher protein group is 2.2 grams. There is a significant difference of 1 gram per kg difference between higher. So this is a very important landmark study, which all the listeners should await and watch for. Primary outcome is to look at 60-day mortality, and secondary outcome is to look at nutritional adequacy and hospital mortality, and discharge from the hospital and mechanical ventilation and all these secondary inputs. Then there is another trial from Saudi Arabia called Replenish trial, which is again a RCT comparing 1.8 to 2.2 grams per kg versus 0.8 to 1.1 gram. It's a small study, 40 patients. Primary outcome is to look at 90-day mortality. So these are some of the randomized control trials which are happening now and whose results are awaited. This is Australian trial, which is also going to be a landmark trial. It is being done by one of my colleagues when I was in Australia, Adam Dean. So it's a prospective randomized control trial comparing higher protein versus lower protein. So these are the list of randomized control trial for all the listeners which are awaited. But one trial I think all of us should look forward is for this effort trial, the last one you see, 4,000 patients. And there are studies pretty much coming from every country, Canada, Netherlands, China, Brazil, USA. So it's going to be exciting in 2021 to see the results of effort and Replenish trial. That would be interesting for us to see. Replenish and the other one which I mentioned, which is the Nexus trial. So the take-home message. So I'm sure you're all awaiting to see what the take-home message. Now I may have confused. RCT said no difference. Observational studies are telling give high protein, it's good. Then there are three group of studies which are telling if you give early, it's going to increase the mortality. I think the simple take-home message comes from this algorithm. If you are dealing in an acute phase, in the first initial 4 days, obviously don't target your protein of 1.3 to 2 grams. You slowly crank it up from 25% of your target on day 1, 50% of target on day 2, and 75% on day 3, which means you are not attaining the target within 4 days, which means the earlier 3 days, which the two studies showed, if you give high protein in 3 days, it increases. So you're not giving high protein, you're only staggering it, slowly cranking it up. After day 5, where your whole recovery may have been happening and patient has sort of settled from his acute illness, that is where you target 1.3 grams per kg, which is on the lower limit. So it's 1.3, no one is telling it's a high protein. You target 1.3, it accounts for 80 to 85% of 1.5 grams or more than that if you're targeting. So after day 5, you target that much. And once you're in a recovery phase where you are planning to shift, because ICU length of stay in India in most good ICUs will fall around 5 days. Okay, 5-6 days you give 1.3. Once you are moving them out of ICU or you have taken them on a T-piece, they're convalescing, then you crank it up from 1.5 to 2 grams per kg per day. So you reach up to 2 in the post-acute phase after 5 days. And then once the discharge from ICU to say ward or from ward to a hospice or to the home, where they're convalescing, that is where muscle building is happening. That is where you crank up the proteins to 2 to 2.5 grams per kg per day. So when you sort of embrace this sort of a staggered approach and this concept, so you are pretty much adopting all the evidence that you have heard from me and subscribing to that evidence at this point of time. So by staggering the protein and cascading the increase over course of time during the course, so you are basically delivering the protein in a very dynamic way. So thank you very much. So I'll end my talk with this quote: the more you know of any aspect, so be it protein, the better you can handle it. This goes for yourself too. When you know everything that is to know, it is called realization. So it is important to dwell into the evidence and understand what all are happening. So thank you very much. Over to Farooq Bhai to take it further.
Yeah. Thank you, Pradeep. I think it was quite a bit of proteins, update from your side, and we look forward for those trials which are coming up, so that we can make a consensus opinion out of the trials that come out in 2021. There are a couple of questions that have come in. This question is to Dr. Karthik. It is from Dr. Ankur. He wants to ask if a patient is on a low dose vasopressors or for that matter any inotropes, when and his conscious, when can enteral feed be initiated? Karthik, you can take that question.
Yeah, Dr. Ankur, when the patient is on a low dose vasopressors, you can definitely start off your enteral nutrition. The only thing is, if they are in severe septic shock requiring high vasopressor dose and they are not absorbing anything, that is when you have to go slow. But if you feel that the patient's condition is not so bad, they're maintaining their hemodynamic status with minimal vasopressors, I think it is perfectly fine to start off. Like how Pradeep said, you can start off slow, make sure you build it up over a period of time, and you can achieve your target once the vasopressor dose also starts coming down. So that would be the way to go.
And I think also, Karthik, in intensive care, we always start off with low calorie. We never start at 30, 35 kilocals on day one. We always build it up from 15 to 20, and over a period of time, max it out, like Pradeep said, to 30, 35 kilocals per kg per day in terms of the total requirement.
Absolutely right. Very true.
Yeah. There is also a second question. He says, what are the steps to be followed if patients are ventilated, sedated, but they have failed their enteral feeding? How will you approach these patients?
One thing that we commonly encounter in our regular practice is not able to absorb the enteral feeds. If somebody's enteral nutrition is not being absorbed properly, then the first thing that we need to do is to make sure that the other reasons are taken care of. It starts from the tube. Position of the tube should be fine. The enteral formulation that has to be given has to be adequate. And if the patient is not absorbing it adequately, the way to go about it is we give a prokinetic in the form of either metoclopramide, 10 milligrams thrice a day. Some people also, at least in the abroad setting, we used to give erythromycin as an intravenous formulation. We don't get that here. So perinom or metoclopramide is the right way to go about. So once you start that, at least there will be a prokinetic effect and the absorption is much more hastened with that. You go slow and then start at lower dose and then build it up over a period of time once the absorption or the regurgitant volume is lesser. So that's the only way to go about. Whatever it is, we have to make sure that enteral route is the only way to go. Just because he's not absorbing it does not mean that you can go on the parental route. We have to persist on the enteral route, whatever be it.
Okay. This question is to Dr. Pradeep. Even though it is not related to proteins, I think Pradeep can take this. There's a question which says, do we have any data or a guidance regarding the recommended dose of vitamins and micronutrients in ICU, especially vitamin C?
Yeah, so see, with regards to the enteral nutrition, these vitamin components are part of the whole commercial formula that you would deliver. So, and all these are incorporated into any commercial feed formula that you would be delivering. Even if for that matter, you're not adopting to commercial feed and you're giving blenderized, whatever requirement, daily requirement of vitamins is needed, that would be provided in the commercial feeds or the diet that you would be giving, because none of us here would be taking additional supplements otherwise, isn't it, with regards to vitamins. So enteral nutrition are wholesome and are good enough to provide all the vitamins that one would need. Vitamin C is a whole topic in itself, Farooq. So I think it depends on what sort of a clinical context we are looking at when you're talking about vitamin C, and it is a whole science in itself now. Albeit, I would say the evidence is sort of waxing and waning in trying to considering it as a standard of care in sepsis patients, or be it our COVID situation. So let's not dwell into that, but whatever daily requirement of vitamin C you would need would be provided from commercially available formula and the diet that you would be taking.
Farooq, if may I add, the dietary requirement of vitamin C per day in a normal patient is around 90 milligrams to 90 to 100 milligrams. So that is in a normal patient, but obviously in a critically ill patient, the requirement would probably be different and much higher. So that is the basis for which the Palmeric study also came about, adding a lot of vitamin C to it.
Correct. Karthik, there's one more question for you. You were talking about disease specific in hepatic, in renal, and all that. So there is a question which says that are we still using the disease specific formula as per the ESPEN and the ASPEN societies, because they say that they don't support this kind of formulation.
Correct.
Any comments on that, Karthik?
Yeah, I mean, right now the disease specific formulations, whatever I mentioned, is more of a theoretical concept, because you don't really go down to that sort of a formulation when you're feeding somebody. So the basic thing that we need to make sure are, if the patient has got a liver disease, two things are to be maintained. One, give a low sodium and make sure that the amino acids are not too many. If you're dealing with a renally impaired patient, make sure you're giving a low phosphate and a low potassium calorie, the diet. And any patient with respiratory disease, make sure that you're giving a high fat and a reduced carbohydrate diet. So these are the basic things that we normally stick to right now.
Okay. Maybe we have time for two more questions. I think Pradeep can take this. This is something which we commonly come across. What about the gastric residual volume? Do we need to check it regularly or not? Or do we just use a continuous feeding pump? So I think Pradeep, you can take this question, please.
Yeah, I think we have now gotten away in checking this gastric residual volume. None of the guidelines would suggest that we should be checking this as a routine to determine the continuum of feeds. Of course, if GRV is very large and you have trouble, then you have to deal with prokinetics. But the whole concept is to persevere and continue with the feeding and not take a absolute quantity to determine whether you would continue or discontinue. But Albert, if you have a huge problem with a lot of aspirates, then you have to take measures to circumvent that with prokinetics and persevere with feeding.
Yeah. So maybe one last question before we move on to the guest lecture. Probably Karthik, you can take this. The question is, in Indian patients at admission, majority of them are malnourished. So do the RCTs hold good for us regarding the timeline?
Timeline of what specifically?
I think probably starting feeds or probably, with reference to the randomized control trials, which Pradeep mentioned about the protein requirements, the low protein, high protein, or maybe even Pradeep can take this.
No. Sorry, Farooq, just tell me again, what is the question?
The question
I think Karthik, you can answer. I'll just take it from there.
Yeah,
looking into something.
It's in the Indian setting. The question was
in the Indian setting, where we have majority of our patients who are coming malnourished, and when we are talking about RCTs where patients are on low proteins or high proteins, so the particular doctor wants to know, does it hold good for us regarding the timeline?
Now, Farooq, first of all, I wouldn't agree with that statement that most of them come with malnourishment, because there are clear definitions for what we mean by malnourishment. That he must have lost weight, and if that history is objectively captured, that there is a loss of weight or there is a pure intake of feeds, because these are specific subset of patients where we would see this, predominantly oncology patients or some GI obstruction or something of that sort. So the first statement saying and assuming that most of our patients are malnourished, that itself may not be completely justified. So when we say malnourished, obviously that is a whole science in itself. Even there, we cannot start away with high dose protein. We have to stagger it because of a lot of refeeding issues that you would have for it. So, so if you have confirmed that he is malnourished, again, there the concepts pretty much remain the same, and there will be a slow and staggered, cranking up of nutrient goals. You wouldn't upfront give very high protein, because even tolerance will not be there, and they would have other refeeding issues.
Sure, agree, Pradeep. Okay, I think we will need to end the session on nutrition now. I will be moving on to the next sponsored talk, which is from the WOCART Critical Care. It gives me great pleasure to invite Dr. Jeshid Ahadil. He is basically a MD in pharmacology from the Government Medical College, Calicut. He is the head of Medical Affairs Antibiotic Discovery Division. He's got more than 10 years of experience in pharmaceutical physician as a lead, and he has more than 15 publications in the index journals. So today he is going to speak to us on a new molecule which is launched by WOCART Critical Care. It is levonadifloxacin, which is a novel benzoquinolone. And I will hand over to Dr. Jeshid to take us through this. Over to you, Jeshid.
Yeah, thank you, Dr. Farooq, for the kind introduction. And first of all, let me thank the ISCCM Bangalore chapter for giving us an opportunity to introduce the first new chemical entity antibiotic from India to the world. So to give you a brief background, WOCAD is into antibiotic research for the last 20 years, and we have 6 new chemical entity antibiotics in the late phase of clinical development. And all these antibiotics are prominently mentioned in the WHO antibiotic pipeline. As we know, many big pharma companies have moved away from antibiotic research, and only a few companies are focusing on antibiotic research. And WOCAD is the only one company which has more than 5 antibiotics in the late phase of clinical development. And we have completed the phase 3 study for these 2 molecules in India, and we have launched this molecule, EMROK and EMROK-O, 2 months back in June. And we know that it's more than 100 years since the discovery of penicillin in 1928, and many antibiotics were introduced from various parts of the world, and what they are either introduced by either discovered in US, Europe, or in Japan. And by introducing EMROK and EMROK-O, WOCAD became the first Indian company to get an approval for the new chemical entity antibiotics. And all these antibiotics, even though they are discovered in India, the studies are done in the US, Europe, as well as in India. And we also have received the QIDP status, Qualified Infectious Disease Product status, from US FDA for these molecules. QIDP is a special status which is given by the US FDA for those molecules which they feel that it will address the unmet need to treat the MDR infection. These also help us to accelerate the drug development cycle. We know that antimicrobial resistance is a rising concern globally as well as in India. The data says that currently around 7 lakh people will die due to AMR globally. And it is estimated that by 2050, around 10 million people will die per year due to AMR. And India carries one of the largest burden of drug resistance pathogens worldwide. And it is estimated that around 2 million people will die due to AMR in India by 2050. That means 20% of the overall global mortality due to AMR will be coming from India. When we look at other pathogens which are causing other infections, bacterial infections which are in Indian ICUs and in hospitals, the gram-negative agents predominates. Around 70 to 80% of the infections are caused because of gram-negative pathogens. But at the same time, the MDR agents contribute to around 16 to 20%, and it also contributes to a significant burden in Indian ICU. And when we look at the mortality burden, the recent multicentric data says that around 16% of the overall patients who are infected with MDR gram positive infections, including MRSA, will die in Indian ICU. There are certain infections where gram positive pathogens predominate, which include acute bacterial skin and infection infection, diabetic foot infection, community acquired bacterial pneumonia, bone and joint infection, febrile neutropenia, and device associated infection. And also 12.6% of the overall sepsis in Indian ICUs are caused because of gram-positive pathogens, and including MRSA. And because of this reason, ISCCM in 2019 guideline of antibiotic prescription in ICU, the experts recommend adding an anti-MRSA agent along with gram-negative in high-risk group who are infected with community-acquired pneumonia, ventilator-associated pneumonia, catheter-related bloodstream infection, skin and soft tissue infection, sepsis of unknown origin, and febrile neutropenia. In this group of patients, you will be adding a gram-positive agent along with a gram-negative in order to get a better patient outcome. And when you get the culture report, you will be de-escalating accordingly. When we look at the MRSA burden, it is also increasing over a period of time. In 2009, it was around 29%, but the recent ICMR data says that in 2018 says that the MRSA prevalence is around 39%. And because of this increasing prevalence, increase the mortality rate, burden to the community as well as healthcare setting, the World Health Organization in 2017 has listed MRSA as a high priority pathogen where research and development need to be focused to bring about new chemical entity antibiotics. For MRSA infections, we do have anti-MRSA agents. The older agents which we have, the glycopeptides, the vancomycin, teicoplanin, they are slow bactericidal agents. At the same time, they have come up with the limitation of nephrotoxicity, ototoxicity, and Bredman syndrome. And as Dr. Pradeep has mentioned, more than 50% of the patient in ICU will have some degree of renal impairment, and it will be a challenge to use glycopeptide in those kind of patients. And ideally, when we give these molecules, the trough concentration need to be measured, but in majority of the setting, the capability is not there to measure the trough concentration. And as a physician, we increase the dose to attain the optimum trough concentration. And again, when we increase the dose, the nephrotoxicity is an issue. The other agent which we have is linezolid. It's a bacteriostatic agent, but at the same time, it has a limitation of marrow suppression, thrombocytopenia, and lactic acidosis. And because of this reason, it's not used for a prolonged period. And also, it is not an approved agent for MRSA bacteremia. The other agent which we have is daptomycin, we know it's effective for pneumonia, and also it comes up with skeletal muscle toxicities. And it is recommended to monitor the creatine kinase level very frequently while on therapy with daptomycin. The other agent which you have is tigecycline. Even though it has an activity against MRSA, it is not routinely used as an anti-MRSA agent because of the black box warning from the US FDA due to all-cause mortality. And also it has a GI side effect, and also it's a bacteriostatic agent. With this background of increasing prevalence and the limitations of the current anti-MRSA agent, we introduced the two new chemical entity antibiotics, EMROK and EMROK-O, which we have extensively studied. We have more than 50 publications in various reputed journals, and we have presented posters in various international conferences. There are 18 clinical studies which we have done, out of which 6 are done in the US, and 1381 subjects are exposed to this molecule. And as we discussed earlier, we have received the US FDA QIDP status for this molecule. What is unique about this molecule is its unique chemical structure. It has a unique benzoquinolisine ring, which will impart potent activity against MDR infection. And this side chain 4-hydroxypiperidine will help in the enhanced permeation as well as the enhanced target affinity in the pathogen. And the carboxyl group will significantly enhance activity in acidic environment. This is IV formulation EMROK. And the oral formulation EMROK-O, it is a prodrug of which is allalevonadiplocin, which is basically an alanine ester of levonadiplocin, which will be rapidly will be absorbed from the intestinal epithelium along with the other amino acid. And within the intestinal epithelium itself, it will be converted into the active formulation, the levonadiplocin, with the help of enzyme esterase. Therefore, the bioavailability of the oral formulation is very high, more than 90%, and also it has a good GI tolerability. The molecule will also come up with its unique mechanism of action, which will inhibit both DNA gyrase and topoisomerase 4 with preferential action on DNA gyrase. We know that many antibiotics, the resistance happens because of the topo4 mutation. And if even the pathogen is resistant for topo4, this molecule will work because of its preferential action on DNA gyrase. And secondly, many antibiotics, the resistance happens because of the no-reflex pump, where the antibiotic is thrown out from the pathogen. But this molecule is not a substrate for no-reflex pump. Therefore, the concentration remains adequate within the bacterial cell for its bactericidal activity. Apart from these two actions, it also has a superior cidal action against biofilms. So all these actions put together will give a potent activity against the MTR gram-positive pathogens, including MRS. Coming to the coverage of this molecule, we have extensively studied about the coverage of this molecule, and most of the studies are done in US. We have tested against the Staphylococcus aureus, both the hospital-acquired and community-acquired. We also have tested against vancomycin-resistant Staphylococcus aureus. We also have tested against pneumococci, the Streptococcus pyogenes, and also the anti-anaerobic activity of these molecules is being tested, and also the atypical pathogen. And all these studies are published in various reputed journals. And apart from that, we also had a large-scale surveillance studies where we have collected the bacterial isolates. We had two programs. One is Centenary program and another one is Aspire program. The Centenary program is a global surveillance program where we have collected more than 12,000 bacterial isolates from 154 medical institutions across 4 continents. And Aspire program is a national surveillance program from India where we have collected 1376 clinical isolates from 16 centers across 12 states. And from all these studies, what we have found that the molecule is having a unique multi-spectrum coverage covering gram-positive pathogen, including MRSA, VRSA, VISA, and even linezolid non-susceptible strains will be covered. It also has a good activity against Streptococcus pneumoniae, both macrolide and penicillin resistant, and also has a coverage against Enterococcus faecalis in gram-positive space. In gram-negative space, it has a good coverage against respiratory gram-negative, Maracilla, and H. influenza, and other quinolone-sensitive gram-negative pathogen. Additionally, it has a good coverage against atypical pathogen, Mycoplasma chlamydia, Legionella, and also has an anaerobic coverage, which covers better than the metronidazole or clindamycin. It covers Clostridium peptide as well as bacteria. So these are recent data which is published from CMC Vellore. It's published in Journal of Antimicrobial Chemotherapy, where they have tested around 793 Staphylococcus aureus, which include 441 MRSA strain. include H-Visa strain and also the Bengal Bay clone, which we know that is the most virulent, the PBL positive community acquired clone. And what they have found that the molecule is 100% sensitive to all these isolates with an MIC of 0.5. But when we look at the other agents, the vancomycin linezolid, their MICs are relatively higher when they were tested with the same isolate, and they are nearing the breakpoint. And we also have developed the susceptibility disk for this molecule, and we with an international partner and Indian partner, and it will be available to monitor susceptibility of this molecule while before and during therapy, and it will also help you to take an informed decision regarding the usage of this molecule. And before the launch of this molecule, we also did a multi-center study to assess the disk performance, where it's been studied in 6 centers across the country. Around 700 isolates been tested, and it's been shown that it has 100% sensitivity, which is with breakpoint more than 17 millimeter. One of the important property of this molecule is the activity against biofilm. As we know, biofilm is a major challenge in while treating the patients like Lyme-related infection or devices-related infection, bone and joint infection, or diabetic foot infection. And we have assessed the anti-biofilm property of this molecule when compared to the other anti-MRSA agent. And this is a scanning electron microscopy image, which you can see an untreated biofilm here. Daptomycin doesn't have an activity against the biofilm, MRSA biofilm. Clindamycin also doesn't have any activity. Linezolid has some activity, but when we look at EMROK, it shows complete and drastic eradication of MRSA biofilm. So this property will be helpful for you to treat your patients who have like device-related or line-related infection, which are complicated by the formation of biofilm. Another property is the high-density killing property of this molecule. We have tested by giving a challenge of 100 times density, and even at a high bacterial load, this molecule has shown a rapid bactericidal activity. And you can see within 3 to 4 hours, it shows a 2 to 3 log kill and is sustained over a period of time. But when you look at the other anti-MRSA agent, the vancomycin, linezolid, daptomycin, or clindamycin, it shows a subdued response that it cannot withstand the high bacterial load. Therefore, in setting of the intensive care setting where you feel that in severe infection where the bacterial load is high, this molecule even work in high bacterial load with a rapid bactericidal activity. Apart from that, we know that the MRSA as well as the atypical pathogen resides within the macrophages, and we also have assessed the intracellular activity of this molecule. We show that the molecule will penetrate well into the macrophages and eradicate the pathogen. And also, it has shown enhanced activity in acidic environment, because many times in the laboratory setting in controlled environment, we can see that the molecule will be susceptible to a particular pathogen. But when we suspect that the pH at the site of infection is relatively lower, many antibiotics may not work. But because of this unique structure of this molecule, the activity will be enhanced in acidic environment for this molecule. For example, this particular strain of MRSA, you can at a controlled pH, the MIC is around 0.5, but when the pH is reduced to around 5.5, the MIC further reduced, which shows that the potency of this molecule is enhanced in acidic environment. Beyond antimicrobial activity, this molecule is also assessed for the immunomodulatory effect. And these are recent data which has been published in antimicrobial agents and chemotherapy, where we have assessed the response in murine acute lung injury model, which has shown that the IL-6 level is reduced with this molecule as well as the TNF-alpha, which shows that it has an immunomodulatory effect apart from the antimicrobial effect, especially in setting where the cytokine level is relatively higher in some of the infection. This molecule may be helpful to treat such kind of infection. And because of this unique mechanism of action, this molecule is also having a low mutant prevention concentration, which is a powerful tool to assess the resistance suppression potential of this molecule. And we know that if we're giving an antibiotic and if the concentration is achieved above MPC, then the probability of the development of the resistance while on therapy will be minimal. For EMROK, the MIC is around 0.5 and the MPC is around 0.5 to 2. And when we give EMROK, the concentration is achieved much higher, 10 to 20 times than that of the MPC. Therefore, the probability of development resistance while on therapy will be less for this molecule. Coming to the clinical studies, as we discussed, we have 18 clinical studies, out of which 6 are done in US. 1381 subjects are enrolled in these studies. This is a summary of phase 1 study which we have done in for EMROK, which is the IV formulation. 7 studies are done, out of which 6 are done in India and 1 in US. And this is a summary of phase 1 study which we have done for EMROK-O, which is the oral formulation. 7 studies, out of which 5 are done in US. The important phase 1 study which were done in US are the food effect and absolute bioavailability study, the thorough cardiac safety study, the thorough QT study, the intrapulmonary pharmacokinetic study, and the hepatic impairment and hepatotoxicity study, which we will discuss in the coming slide. Coming to the pharmacokinetics of this molecule, as we discussed, the oral formulation, which will be absorbed very rapidly from the intestinal epithelium, and it will be converted into the active formulation within the intestinal epithelium itself. Therefore, it has a short Tmax and high Cmax, and the bioavailability is more than 90% for this molecule. And the phase 1 study which we have done in the US has shown that food does not alter the bioavailability of this molecule, and therefore can be taken with or without food. Metabolism is through liver, but it's not going through the cytochrome P40 metabolic pathway. It's basically going through this 2-pathway conjugation pathway with levonorgenicloxacin sulfate as the predominant metabolite. Since it's not going through the CYP enzyme pathway, those concomitant medications that we are giving to the patients, like the anticoagulant or anti-diabetic, which go through the CYP enzyme pathway, will not have any drug-drug interaction with this molecule. It is distributed well into the tissues with favorable tissue and unbound plasma concentration. Excretion is happening through both urine and feces, but importantly, the unchained drug which is passing through urine is very minimal, less than 3%. Therefore, the pharmacokinetics are not expected to be altered in renally impaired patients and can be safely given to the even to the severe renally impaired patients. When we look at the pharmacokinetics between IV and oral, it is matching and superimposing. When we look at the Cmax, the half, and AUC of oral formulation, it is similar to the IV formulation. Therefore, the potency of the oral formulation will be as good as the IV formulation. And as we know, currently, the only available oral agent is linezolid, and that too is a bacteriostatic agent for MRSA infection. Being a rapid bactericidal agent without the limitations of the side effects profile of linezolid, this can be a better option, and it will help for easy switchover from IV to oral formulation. And we also have assessed the intrapulmonary pharmacokinetic study. And this is a phase 1 study which we have done in US and is also published in Antimicrobial Agents and Chemotherapy. And we show that the drug penetrates well into the lung tissues. In fact, the epithelial line fluid concentration is more than 7 times that of the unbound plasma concentration, and alveolar mucus concentration is more than 2 times that of the unbound plasma concentration. Therefore, this high penetration to the lung tissues will help you to treat your lung infections, which are caused by both intracellular as well as extracellular respiratory pathogens. The study, phase 3 study, which we have done in India, is also published very recently in JAPI this month. And the comparator used was linezolid. The reason being that linezolid is the only agent which has an oral formulation. And we have studied with 501 subjects across 30 centers across the country. And the infections studied are acute bacterial skin syncytial infection, which include severe infection, cellulitis, and also the diabetic foot infection and patients with concurrent bacteremia. And what we have found that the molecule has a good clinical response, with 91% patient had a clinical cure with EMROK, while opposed to around 87% with linezolid. But when we look at the diabetic foot infection patient, 91.7% had a clinical cure with EMROK, while only around 76% had with the linezolid had a clinical cure. The reason being that the molecule, EMROK, penetrate well into the lung tissues and to this the skin and soft tissue. And also the biofilm is a major concern in diabetic foot infection, and maybe because of the anti-biofilm property, this molecule has shown a better response in diabetic foot infection. And again, when the pathogen isolated in the study is MRSA, again, it shows a better response, with 95% patient had a clinical cure with EMROK. The molecule is well tolerated in clinical studies, and there are no severe adverse events reported in the studies. And this is a summary of adverse events reported in phase 3 studies, where all side effects reported were mild in nature. The only side effect which is reported in more than 1% of the patients with EMROK is constipation. That 3.6% had a constipation with EMROK, while linezolid also has 1.6% had constipation. But all these patients were hospitalized patients with severe infection, and we know that the hospitalized patients tend to have constipation. And there are no major other adverse events reported with EMROK. And we also have studied the thorough QT study, the cardiac safety study, which is also done in US, which is also published. And here we have given a supratherapy dose of 2,600 milligram to the patient and have assessed the QT interval prolongation. And it shows that It doesn't have QT interval prolongation, or doesn't show QT interval even at a supratherapy dose of 2,600 milligrams stat, which shows that it can be given safely to your cardiac patients and also to patients who are at risk of QT interval prolongation. And we also have done the hepatitis safety study and hepatic impairment study that's also done in US, which shows that the drug doesn't have any hepatotoxicity or liver enzyme elevation, and there is no dose adjustment required even in severe hepatic impaired patients. So the overall, the molecule is well tolerated with a good safety profile in comparison to existing or in development anti-MRSA agent. It has a good GI tolerability, no hepatotoxicity, nephrotoxicity, no QT interval prolongation, no phototoxicity, and there is no dose adjustment required in elderly patients and patients with hepatic impairment. The dosage for this molecule is 800 milligram IV for the IV formulation. It need to be given as an IV infusion over 90 minutes twice daily. Oral formulation is 1000 milligram twice daily. It can be given with or without food. The absolute contraindication is that we don't have studies in children, pregnancy, and lactation, so it's contraindicated over there. And those patients who have a non-hypersensitivity to other quinolone agent, it's contraindicated. And patients with history of tendon disorder also, it is contraindicated. As we discussed, the molecule is not going through the CYP enzyme pathway. Therefore, the drug-drug interaction is very minimal, and we don't recommend to co-administer with multivalent cation through the same IV line. And using special population, we have already discussed in hepatic impairment, there is no dose adjustment required. Renal impairment, since the excretion is very minimal through your kidney, the pharmacokinetics are not expected to be altered. And geriatric patients who are on steroid, caution should be used while using EMROK. Considering all the potential property of this molecule, the potential indications for this molecule is one is community-acquired bacterial pneumonia, as it covers almost all respiratory pathogens, including the macular and penicillin-resistant streptococcus pneumonia. It has shown good lung penetration with high ELF and ALM concentration, and being a rapid bactericidal agent, availability of IV and oral, and even the lung environment, we know that the pH is less, therefore the enhanced over there. And because of these properties, one of the potential indication for this molecule is community-acquired bacterial pneumonia. Second potential indication is catheter-related bloodstream infection, because the biofilm is a major concern over there, and due to its anti-biofilm property and broad-spectrum activity and rapid bactericidal activity and availability of IV and oral, it can be used for catheter-related bloodstream infection. Bone and joint infection, we know that it needs an antibiotic which is safe to be used for a prolonged therapy, and also its biofilm is a major concern over there. Being a broad spectrum agent with a rapid bactericidal activity, anti-biofilm property, and so a safer molecule to be used for a longer period, we believe that this molecule will be working very good in bone and joint infection. In febrile neutropenia, even though the gram-negative pathogens predominates, but the immunocompromised setting, where we also have a study in the animal model, in the neutropenic mouse model, which shows that the molecule eradicates well the pathogen in various lung model. And owing to its superior safety profile and also the rapid bactericidal property, and this molecule can be considered for febrile neutropenia as well. So how is it different from other anti-MRSA agents? The independent expert, has also published a recent article where they compared the clinical, pharmacological, and antimicrobial profile of this molecule with other anti-MRSA agents, and it has shown that it is much superior than the currently available agent because of its both IV and oral formulation, and it has a rapid bactericidal killing property. The lung penetration is excellent. It has a coverage, it has partial coverage against gram-negative. It has a good coverage against visa and aerobes. It has a good GI tolerability, anti-biofilm property. There is no kidney toxicity, GI toxicity, myelosuppression problem, and there is no dose adjustment required in hepatic and renal environment. The drug review of this molecule is also published in a PubMed Index journal. So what all things, the data which we have presented, it's published as a drug review, and it's also published. And I'll share the link to these articles through the comment box. To summarize, we had a unique molecule, EMROK, with a unique chemical structure. Owing to the unique chemical structure, it has a unique mechanism of action inhibiting both DNA gyrase and topoisomerase 4. It is a rapid bactericidal activity. It is owing to the superior safety, it can be given for long-term use. There is no dose adjustment required in hepatic impairment. It has both IV and oral, so it's easier to switch over from IV to oral formulation. It has good lung penetration in various tissues, including lung. It has anti-biofilm property. It eradicates the biofilms. and also it has a broad spectrum coverage covering gram-positive pathogen, including MRSA, respiratory gram-negative, and anaerobes and atypicals. So I try to go a little fast because I had to present the 20 years of work which we have done in 20 minutes. I tried to go a little faster. So I'll be happy to address any questions if it's coming up. Thank you very much.
Yeah, thank you, Jaishit. First of all, I would like to congratulate WOCAD Critical Care, and as an Indian, I'm quite proud, to have an Indian company having a US FDA approval and to launch it in a world market, speaks volume for the amount of research and development that you guys have put into this particular molecule. I remember Mr. Ambar Mishra inviting me for this key opinion meet when we met in Mumbai about one and a half years back, and where he was very upbeat about this molecule. And going through your presentation now, I'm sure it holds a lot of promise. And to just summarize, Jaishid, about this particular molecule, as I understood that it has both gram positive, gram negative, coverage, and it also covers the atypical and it covers the anaerobes as well, and particularly has action against MRSA, VRSA, and Visa, and also it is effective against strep pneumonia and H influenza as well. And what interested me most is that whenever we are dealing with antibiotic resistance, uh, most of the time when you have this efflux pump mechanism, or you have this gyrase or the topoisomerase mediated resistance, it is able to overcome both these mechanisms of antibiotic resistance, which makes me very interesting, and I'll be more than happy to use this molecule as a clinician bedside to see how it responds in my patients. The other features that I thought this particular molecule had a promise was it's a bactericidal drug. It has got both IV and oral formulations, so the bioavailability is more than 90%. And especially in hepatic patients, you don't require any dose adjustments, and it works also very well in acidic pH. So these are the few, I think, highlights of this particular molecule. So now I also invite Pradeep and Dr. Karthik to give their comments on this particular molecule, and if any queries from the audience as well.
Yeah, Karthik, you go ahead.
It'll be interesting to see how it fares in clinical practice, Jaishit, because it all looks very, very promising.
So we have launched this molecule in June, so it's almost 2.5 months, and most of the metros, most of the clinicians have used this molecule, and the feedback that we are getting is very encouraging, and most of the critical care specialists have used and ID specialists have used, and the feedback in the various clinical setting which I have mentioned in community acquired bacterial pneumonia, the bone and joint infection, and as well as the intensive care where they use as an empirical therapy, where they see that it's a high risk patient. They are showing. The feedback which we are getting is very encouraging. I understand, sir, your clinical experience matters, and of course,
the oral formulation is available as a 500 mg tablet, is it? Because you said 1000 milligrams, 2 tablets, what it said.
Yes, sir. So it's a 500 milligram tablet. So we have to give 2 tablets together twice daily. So in the morning 2 tablets and the evening 2 tablets, because it's coming as a 500 milligram tablet.
Yeah, so very nice presentation, Jaishid. So very interesting, because we learned quite a bit about the way it acts and some of the distinctive effects on your biofilm and some interleukin 6 levels. So I think the test of this molecule, as we would all agree, would be seeing how it compares vis-a-vis with other gram-positive antibiotics in a clinical situation, or a clinical data for that matter. So I just had few queries, and how is this drug excreted, and what is its half-life, and is it concentration dependent drug? So have you done any sort of a info on the pharmacokinetics and the pharmacodynamics of this?
Yes, sir. So we have extensively studied about the pharmacokinetics of this molecule. So it's a concentration dependent molecule, and the AUC by MIC is the PKPD determinant for this molecule. And the metabolism is happening through liver, but it's not going through the CYP enzyme pathway. It's basically going through the phase 2 pathway, the conjugation pathway. One advantage is that it will not interact with those drugs which are going through the CYP enzyme pathway, because many a time the drug interaction happens over there. So the excretion is happening through both urine and feces, But the point to note is that the amount of drug, unchanged drug, which is passing through urine is very minimal, less than 3%. Therefore, the pharmacokinetics will not be expected to be altered even in severe renal impaired patients, because even when one organ is compromised, it will excrete to the other organ. So that is one advantage for it can be used in both renally compromised patients as well as hepatic compromised patients.
Okay. The other queries I had was, since it belongs to quinolone group, isn't it? So see, the whole our thought process about using quinolones in Indian circumstances is to keep it as an ATT or second line sparing drug for tuberculosis. And that is the reason we would want to use them judiciously. Suppose we are considering using levofloxacin for that matter. So our whole concern would be to preserve this drug mainly against tuberculosis. So is this having any similar action against tuberculosis where, we may have to have that sort of a thought process? That is one. The second thing is, especially the quinolones, levofloxacin, it has some seizure thresholds, So has this drug also, has it been looked into that aspect?
Yes, sir. So it's a very important question, sir. So even though, sir, it's coming under the broad category of quinolone, it's coming as an entirely different. Benzoquinone is in subclass of quinolone. So when we look at the mechanism of action of this molecule, it is entirely different from the quinolone. When we look at the coverage of this molecule, it is also different, because the classical quinolone will not cover MRSA and anaerobe. This molecule, in addition, will cover the MRSA as well as anaerobe. And also the safety profile is much better when compared to the other quinolone. For example, the classical quinolones like moxifloxacin, the QT prolongation is there, but we have also showed that in phase 1 study there is no QT interval prolongation. And ciprofloxacin have some hepatotoxicity. It is not shown in even the hepatotoxicity. So this molecule will not cross the blood-brain barrier. So one advantage is that it will not have seizure potential. Second, the disadvantage is that it may not be useful for the CNS infection. It will not helpful for many infections. And we also have SS, even SS in animal models, sir. So what we have done in animal model, we have directly tried to find out the seizure potential of this molecule. We try to directly inject the molecule directly intrathecally. So we took ciprofloxacin as a control, and with ciprofloxacin around 15 microgram, when we inject intrathecally, the seizure and it died. But even at a 5 times the higher dose, even at a 100 microgram dose intrathecally in mouse model, it didn't produce any seizure potential. And the clinical studies which we have done up to phase 3, no patients has report the seizure potential. Secondly, the first question which you have asked about the ATT. So as of now, we don't have any data to show or to show the antitubercular activity. So as of now, we don't have any data to show that.
Okay.
So secondly,
and I just missed the IV dose. What is the IV dose you said?
Sir, it is 800 milligram.
Okay.
It need to be given as an IV infusion for 90 minutes. And it's coming as a ready-to-use infusion bottle of 100 ml. Because many a times we know that linezolid is coming in the volume. I mean, in ICU setting, volume always matter. And linezolid is coming with a higher volume. And this molecule is coming with a 100 ml ready-to-use bottle.
Okay. And you said there's no renal adjustment.
There is no renal adjustment required, sir, because the excretion is very minimal through urine.
Okay.
And as you rightly mentioned, sir, more than 50% of your patient will have some or the other kind of renal impairment in ICU setting. And many a times nephrotoxicity is a major concern over there, and vancomycin, teicoplanin, we try to avoid. And also, the recent article, one of the article was showing that linezolid, the metabolite can cause some renal toxicity. There is a recent article which came from linezolid as
well. So I think few conditions where we would consider using such gram-positive cover, Jayshed, as you have already elucidated that your lung epithelium concentration is very good. So that is one condition where we may contemplate MRSA cover. And the second one, which you again covered, was skin and soft tissue, because that is another important group where we consider this MRSA cover. And you mentioned, it appeared to me that it is very effective.
Yes.
The third area where we would consider is intra-abdominal infections, especially the biliary sort of infections where we would deal with Enterococcus fecalis as a bug. So I never saw you mentioning whether it has a good biliary presence or
Sir,
GI
yes.
penetration.
Sir, it penetrates well into the almost all soft tissues, including liver. It will cover well the Enterococcus fecalis as well. But the coverage to Enterococcus faecium is relatively less. Faecium is relatively less, but Enterococcus fecalis, it has very good coverage. And even except MDR gram negative, almost all pathogens will be covered with this molecule. So you may not add an anaerobic coverage like metronidazole or clindamycin, or sometimes we add a macrolide for lung infection where there is a atypical coverage. That additional antibiotics may not be required when we use EMROK.
Jashid,
Yes, sir.
like you also rightly mentioned, see, gone are those days when we used to predominantly think that our Indian ICUs are more of gram-negative ICUs, because as you rightly mentioned in your presentation, we also see a lot of gram-positives. So as a company, are you people trying and promoting it more as an empirical along with a gram-negative cover? Or do you say it can be used as a monotherapy because it covers thing, or is it used in a combination therapy? What is the thing for as a company take?
So, still, I mean, as you rightly mentioned, even though the gram positive is there, still the MDR gram negative is a relatively higher problem in our ICUs. Since this molecule will not cover the MDR gram negative, we propose you, whenever you think about adding a gram positive agent like a teicoplanin, vancomycin, linezolid, or daptomycin, instead of that, you can add this molecule as an empirical therapy along with MDR gram negative agent, along with MDR gram negative. And of course, the sensitivity discs are also available. And depending upon the sensitivity on the third day or fourth day, whenever you get the culture report, you can de-escalate accordingly. So to summarize, we propose to add it as along with an MDR gram negative empirically initially, and then de-escalate accordingly. So.
Can I just make a point, Dr. Farooq, if you, with your permission, sir?
Yeah. Hi, Amber. Nice to see
Hi,
you.
sir.
Go ahead, Amber.
Good evening, Dr. Rangappa. You were mentioning, sir, the potential usage areas for the product. Now, one of the areas which would be very important would be line-related infections, because we saw a biofilm study where the other anti-MRSA agents were virtually exposed because of their poor biofilm penetration and coverage. And especially in high-density Staph aureus, this seems to work well. So if it's line-related infections or catheter-related bloodstream infections, we are getting a good feedback in that area as well. One other area is febrile neutropenia and post-febrile neutropenia. Secondary infections include gram-positives in the ICU. And there again, the product seems to be giving a good response. But more importantly, MRSA bacteremia, because the product is licensed for usage in concurrent bacteremia. So MRSA bacteremia, I do understand that it's approximately 12%, 13% of the overall incidence. But in MRSA bacteremia, sir, this product is also likely to give a good result. This is over and above polymicrobial infections like diabetic foot ulcer patients and ABSSI, including wound infections and concurrent bacteremias, which we talked about, sir.
And even the bone implants, I think that's also another area.
Yes.
So one feedback which I would like to share about one of the patient who has been given. So it was one of our first patient. Basically, that patient was on osteosarcoma patient who is amputated, and the stump got infected with MRSA. And the doctor, it's basically a patient from the south, and the doctor has started with linezolid because it's MRSA. But even after 2.5 months giving linezolid, the patient didn't respond well. And then the doctor was put the patient on teicoplanin, but the patient didn't cannot tolerate teicoplanin. Teicoplanin related reactions occurred to the patient. And during that time, at that time we were launching this molecule, and the doctor called, and the patient was put on EMROK, and the patient the patient is still on EMROK. It's more than 1 month now. But after within 15 days itself, the count started reducing, the CRP got reduced, and the patient's symptoms got reduced. And after 1 month, he is relatively stable, and the patient is still continuing on EMROK for 2 weeks. It was given by an ID specialist from South. So it shows a very promise in bone and joint infection as well.
So I think like any other drug, we would ask you, what
Yes.
is the cost in comparison to our conventional gram-positive coverage antibiotics number?
So,
So that would determine our usage. And the second thing is, I think it would be good to look into comparative studies, which is pretty easy to do, Amber. The way I would look at it is, we possibly pick up 30 patients, use it, and compare with our historical cohorts and see if there has been any change in the clinical outcome by matching the baseline characteristics. So this is a simple sort of a observational study we could look at to gain confidence.
Sure, sir. So the phase 3 study which we have done is already comparing to the linezolid, that is already done. And the phase 3 and phase 2 we have compared with vancomycin already. But of course, your clinical experience and the post-marketing experience really matters too.
So just to take your question on the pricing, we have, as stated earlier, an 800 mg per 100 ml bottle, IV infusion bottle, which is costing 3,200 rupees. And it's a BD dosage, so the cost of daily therapy amounts to 6,400, sir. In comparison, daptomycin is around 5,000 per dose currently, and teicoplanin with the loading approximately 4,500. Tigecycline is approved for MRSA usage, even though not used much, around 4,000 rupees per dose. Whereas linezolid and vancomycin would be the low-end, low-cost options currently, because vancomycin in particular comes under the drug price control order, and therefore under the government regulation, the costs are currently under control. So that's how it compares vis-a-vis the rest of the agents. In terms of the tablets, we have 500 mg tablets, and the cost per day would be 25% lower than per day cost of therapy of the IV. We decided to go in for this kind of pricing primarily to ensure. So we went by the linezolid experience as well. Linezolid, because of misuse, today the usage has to be done with a lot of care. And clindamycin also, in a very short span of time, there are various papers which are talking about 30% resistance. So having done a lot of hard work across 2 decades and having a patented product, which is also mentioned on the pack, the whole idea was to ensure that we propagate the right usage in top tertiary care centers only. And that's what we tried to achieve. Having said that, sir, we have done 18 clinical trials, 12 in India, 6 in the US, and we have approximately 1,400 subjects. So it's a very well documented product. It's a very well documented product across the 3 phased studies. And we have nearly 56 publications in reputed journals like Journal of Antimicrobial Chemotherapy. And therefore, we've opted for this strategy when it comes to pricing, Dr. Sir. Last point regarding the comparative studies. Yes, we are very keen to build an Indian database on the product. Even though we have a very well-documented product, sir, we are very keen to take this forward. So like any gram-positive product, the initial studies are done on skin and soft tissue, or maybe a community-acquired pneumonia and concurrent bacteremias. Going forward, we are doing some investigational studies in bone and joint infections, and we're picking some other indications like febrile neutropenia, so that we can have an Indian database. And we would like to definitely go ahead with a comparative study in the near future. As time progresses, we'll add new indications and have comparative studies vis-a-vis the existing agents, the other anti-MRSA agents.
So Amber sir, you may take the availability in Bangalore also, that Dr. Pradeep sir and were asking about the availability in Bangalore.
No, the product is available since the month of June. And as I have already stated, it is being used in tertiary care centers. One point, sir, which I think would be important from a clinician's perspective, we have an international tie-up for sensitivity discs and an Indian partner as well. We are providing sensitivity discs and also educating and updating the microbiologists with the relevant data in terms of not just the disc volumes, but also the zonal diameters, etc. so that clinicians can take an informed decision. And in fact, we did a 6-center study along with the launch in top tertiary care centers. And I'm happy to state that in the gram positive arena, obviously the results are more than 98% in terms of susceptibility, which is really very encouraging. Even if we take into account linezolid non-susceptible strains, macrolide resistant strains, the results are really, really encouraging, and clinicians are really obviously happy with the outcomes, sir.
Okay, Amber, there's a question to Jayshed. In the era of COVID-19, does this drug hold promise, considering that it has a good lung penetration and an anti-IL-6 activity, and there is no dose adjustment required for renal and hepatic impairment?
Sir, of course, we don't have studies as of now, but there is already one case study which is from Hyderabad, where the patient is a HIV patient, basically got COVID as well, and came up with MRSA pneumonia. And the patient was put on EMROK, and it has gone a good. A patient has had a clinical cure within 5 to 7 days. But as of now, we don't have any large-scale data on COVID, but it shows promise because of its lung penetration is the highest. Because when we compared, even one of the major quinolone which has the highest lung penetration is levofloxacin. It is much higher than the levofloxacin. And secondly, as the data shows, it has an immunomodulatory effect as well. So it shows promise in that setting as well.
Okay.
So I think my comments, Amber, for so this drug definitely excited all of us in the whole presentation. But after you said the cost, it has underwhelmed our excitement, because considering you are all made in India and the concept, and we are here to really encourage all our Indian friends. Should we have kept the pricing little more competitively for making us more zealous in using this drug, Amber? Because Ticoplanin, coming from a Sanofi stable, has put the price maybe a tad lesser than yours. So considering this situation and being made in India, where we need to really encourage this product to make a lot more inroads, my only interim thoughts would be, should we have priced it a little more, in an altruistic way? What do you think, Farooq and Karthik?
If I'm permitted to give a 30-second response, thank you for your very valuable comments, and I really value the feedback which you have given. But having said that, sir, if we we learn from you, but at the end of the day, we have a very rapidly bactericidal agent which is available, unlike the existing agents, which are all either bacteriostatic or slowly bactericidal. And the MIC creep impacting them is a very big issue today. In fact, for one or two agents, this serum concentrations monitoring when the patient is on therapy is a little bit of an issue as well. This guarantees safety from all kinds of monitoring as well, and offers biofilm penetration a better coverage to add to it, because this covers not just gram positives but also anaerobes and atypicals. So that coverage doesn't exist with neither linezolid nor Vanco, and neither does it exist with Tico. Plus, at the end of the day, sir, no nephrotoxicity reported over the last 1400 subject data which we have. No nephrotoxicity, no thrombocytopenia, no QTC interval prolongation. So that allows long-term use without much issues. And obviously, we've talked about special population renal impairment and hepatic impairment. So we have a product which is definitely a superior anti-MRSA agent vis-a-vis the other existing agents at a minor price premium, and with a lot of clinical data as backup, and therefore we've kept the pricing. So we were worried that misuse would lead to development of resistance, and that is why we've kept it that way. But we are supporting with samples in case required for the oral product. And the oral product is a revelation. In fact, it uses the ester bond technology, which has come up first in antibiotics to develop a rapidly bactericidal oral agent. Linezolid is a bacteriostatic one. Here, the bioavailability is more than 90%, sir. And food does not alter bioavailability for the oral agent, which is rapidly bactericidal. So therefore, it allows faster discharge maybe from the hospital, because it is at par with the IV in terms of its impact. considering the features and the efforts put in, and to ensure that the product has a longer life and it's rightly used in the right direction, we came up with this. But your feedback is very well accepted, sir, and we do value your opinion, sir.
So to add to that, sir, as I discussed, we have other 4 molecules, again, 4 more molecules in the pipeline. And 15% of the overall revenue from WOCAD is going back to the R&D. So that is also just thought of, as a, from the research background, I thought I should add to that.
Thank you.
Okay. Any more comments, Pradeep?
I think it's an exciting drug. Possibly we need to do our own internal few studies and just gain a little more confidence, because and sensitivity is something I think they should meet our microbiologists and work on that as well. And but I would agree that many of these gram positives, we would assume that they are sensitive to these newer agents. But it is good to get that official, formal reporting as well for us to be a little more objective on its usage.
I'll just take 30 seconds more, sir. A small, very interesting point. When we were doing our anaerobic study, they decided to do it in the US because in India, the facility for sort of identifying anaerobes and then measuring the results was a little problematic. So that's why some of the studies were also done in the US, and we have really done some hard work on the discs and the susceptibility data. And we assure you of providing for academic support to the microbiologists in hospitals along with the discs doctor.
All right. So I think, Pradeep, I think we will end this session here. Ambar, thank you so much for being associated with the Bangalore Chat by ISCCM. And
Giving us
thank you, Jashid. Yeah, thank you. And I think we will be ending this thing. And Vinay, I think we will be closing down the session now.
Thank you.
Okay, thank you, sir.
Thank you. Thanks, everyone.
Thank you.
Yeah. Thank you, Ambar. Nice meeting you all. Thanks, Jai.
Thank you.
Thank you, Pradeep.
See you, Anna.
Bye, Farooq.
So, Ambar, before we wind up, we look forward for your participation in our ongoing academic activities, and don't forget the landmark GICS event, which I'm sure Farooq Bhai would have spoken to you about.
Yes, sir, he's mentioned that, and we are very keen to engage in all academic fora because we are promoting a science-oriented product where nearly 2 decades of research has been done. And in fact, I just want to end by saying first time from India for India, sir. Never before in the last 100 years, we've had a research antibiotic from India. First time from India to the globe. A great honor for me and my team to present to key opinion leaders India's first research antibiotic today, doctor.
Yeah. Great.
Thank you.
Good luck, Amber. Good luck, Jayshit. Thank you very much. And have a great evening.
Thank you.